Hello, and welcome to this Metro Crisis Coordination Program presentation, Overview of Services and Making a Referral. The objective of this presentation is to provide you with information regarding our history and mission, explain our services and eligibility criteria, inform you of how to make a referral, and highlight the ways in which case managers can support their team during MCCP involvement. Metro Crisis Coordination Program, or MCCP, was founded in 1996 through a collaborative effort among Anoka, Carver, Dakota, Hennepin, Ramsey, Scott, and Washington counties. Over the years, our team has grown and services have expanded to include people served by the CADI waiver. In the upcoming year, we plan to add additional crisis beds for children and adolescents. Last year, MCCP received approximately 675 referrals, and we are on track to do the same this year. MCCP was developed by the participating counties to provide a safety net of services for people with developmental disabilities or mental health diagnoses who are experiencing a crisis. It is the goal of MCCP to provide these services in a time-sensitive, cost-effective, and preventative measure-focused manner. The best time to call MCCP is when you first see a problem developing. The hope is that the crisis may be able to be prevented or reduced in its intensity. The ultimate goal of crisis prevention is to reduce psychiatric hospitalizations and help people remain in their community placements. In a timely manner, we work in conjunction with the person's team and aim to prevent crisis that affects people's home, work, or education. The MCCP team is made up of a diverse group of 18 people, including positive support specialists, a staff augmentation specialist, information and referral specialists, and consulting professionals, including a psychiatric nurse, psychologist, and psychiatrist. MCCP's primary services include technical assistance, staff augmentation, and information and referral. Technical assistance is provided by positive support specialists who provide behavioral assessments, supports and strategies, and trainings to better support the person. Staff augmentation is to mentor caregivers in the implementation of the supports and strategies provided by the positive support specialist. And information and referrals, which maintains the pool of referrals made for crisis bed placement, facilitates the prioritization for crisis bed placement, and provides ongoing support for crisis home providers.
Let's talk about additional details for the services we provide. The first we'll talk about is technical assistance. When we talk about timely services, we mean that services start within 3 business days for preventative cases and within 48 hours for emergency cases. We are a short-term provider and involvement is limited to 90 days. Within these 90 days, we are able to provide up to 30 hours of support to a person's team. With services being short-term and our ability to start quickly, it is important for us to get as much information from the case manager and team as possible. Some additional things for you to know about technical assistance. We serve kids and adults at any age. There is no wait list for services. Services begin immediately. The day the referral made is the first of the 90 days of our involvement. We don't have an intake meeting. Contact with the family is made 1 to 3 business days after the start date to set up an interview. We go out on location to where the person is having difficulties. They don't need to come to us. Don't wait until it's a full-blown crisis. Make a referral when the need first arises. Let's talk about additional details for the services we provide. First is technical assistance. When we talk about timely services, we mean that services start within 3 business days for preventative cases and within 48 hours for emergency cases. We are a short-term provider and our involvement is limited to 90 days. Within those 90 days, we are able to provide up to 30 hours of support to a person's team. Being short-term and our ability to start quickly, it is important for us to get as much information as possible from the case manager and team. Some things for you to know about technical assistance. We serve kids and adults at any age. There is no wait list for services. We go out to location to where the person is having difficulties. They don't come to us. Services begin immediately. The day a referral is made to us is the first of the 90 days of our involvement. Also, we don't have an intake meeting. Contact with the family is made 1 to 3 business days after the referral is received to set up an initial visit and discussion. Please don't wait until it's a full-blown crisis. Make a referral when assistance is first needed. The first support we will look at is the 4-stage crisis plan. Sometimes it's called a behavior support plan or a BSP. This is usually a 1 to 2 page document that breaks down the person's behavior into 4 different categories or stages. In addition to the behaviors being broken down into the stages, the strategies are also separated into different categories as well. This makes for a great quick reference sheet as there's a ton of information all in one place. Let's break down the stages. Stage 1 is considered the person's baseline or their optimal functioning level. Information here includes what things look like for a person when they are happy, calm, and regulated. It might include activities that they enjoy as well as some of their strengths. Strategies for this level focus on ways to help them maintain their success. Stage 2, antecedents. Stage 2 will include triggers and warning signs. The strategies here will be geared for initial de-escalation and redirection, and they are preventative in nature. Stage 3, crisis. Stage 3 is the challenging behaviors that are displayed, and the strategies are more reactive now that the person is escalated. Stage 4 is the resolution, which is what the person looks like after things have started to calm down, with the goal of returning to stage 1. This could include someone crying, someone needing space, or having the person help clean up after they threw things. It is extremely personalized plan, and the strategies will vary significantly from person to person, ensuring that they are most helpful to the person in crisis. The second tool is an assessment and considerations document. This document is a compilation of all information gathered during the course of the case, as well as ideas and considerations for the team. We start with the background information, i.e. the person's diagnosis, current concerns, and pertinent information regarding where they live and work. We look at the possible function of the behaviors of concern, which then leads to strategies to support the person. This document is written for the specific team, so it might be long or short based on the team's needs. In addition to it being useful for the current team, it's good information for when new team members are added or a new provider is introduced to the team. We review proactive and reactive strategies, as well as triggers for the person's behavior and ideas of what to do when specific behaviors occur. Next, let's talk about visual tools and supports. When talking about visual supports, there are many different kinds, including multiple ways to address the same area of concern. Some of the more common visual tools are visual schedules, which could be written or with pictures, reinforcement programs and charts, social stories, and visual reminders for coping skills. When these tools are developed, it is most helpful to be able to get input from multiple team members, as ultimately it is the team member who will be using the tools. So they need to be functional for the person as well as manageable for the team to implement. Last type of primary support we offer are trainings. The trainings we do are a basic overview of information and what might be playing a role in the individual's behavior. We are not PhD experts in every possible diagnosis and strategy out there. The goal of the trainings is to learn how a person's diagnosis is impacting their functioning level, learning style, and ways they communicate. Once we know and understand these things, we can better support the individual. Trainings can be done in person or virtually and are frequently done during staff meetings. For trainings in the family home, siblings, extended family members, and PCAs are also encouraged to come if they assist with caring for the person. In addition to person-focused strategies, we can provide non-client specific trainings as well. Now that we have covered all the different aspects of technical assistance, we want to take some time to clarify some things about our services and what role we play. In addition to the bullet points listed here, it is important to point out a few additional things. We focus on the function of the behavior in the context of the client's life. We look for what is helping and not helping the person to be safe and stable, rather than what's good or bad. We do not pick sides in any disputes or engage in conflict resolution. We are flexible to work around the team's schedule and to set up observations for the times when the behaviors are likely to occur. For example, if a person has difficulties getting on the bus in the morning, then we try and set up a visit at that time. Keep in mind our visits and appointments are arranged in advance, and we are not able to respond in the moment of a crisis or fill in staffing gaps if someone calls in sick or there isn't coverage for a shift. Remember, behavior is complex and dynamic and requires the team's participation to change. Collaboration between MCCP and all team members gets better results than MCCP independently developing something. Staff augmentation is another service available to those receiving technical assistance through MCCP. The staff augmentation specialist works directly with caregivers and provides more intense role modeling, training, coaching, and mentoring on the implementation of the suggestions created by the positive support specialist, also known as a PSS. While the PSS's time is more limited, the staff augmentation specialist is able to work up to 200 hours in the same 90-day period. Services for staff augmentation are initiated by the county case manager and must be in conjunction with an open technical assistance case. The staff augmentation specialist will be focused on role modeling and training caregivers. That means some things that they're not able to do. Though they might be with a person for a number of hours, it is still the staff or caregiver's job to administer any medications or first aid that might be needed. If there's any physical intervention needed, That is the responsibility of the caregiver or staff. It is also important to note that even though up to 200 hours may be authorized, those hours are not guaranteed. Staff augmentation specialists are scheduled for 1 to 2 weeks at a time, and supports may end after 2 weeks, depending on the need of the team and other needs that might develop with other individuals.
MCCP is the centralized entry point for crisis placement for the Metro County system. The Information and Referral Team maintains a pool of individuals waiting for placement, coordinates this placement, and provides ongoing support for the crisis homes in the metro area. When a team is requesting a crisis bed, it is the INR team who will be working with them. Referrals for TA and INR can be made simultaneously if needed. There are currently 16 child-adolescent crisis beds. 12 are for kids on the DD waiver, and the other 4 are for kids on the CADI waiver. There are 24 adult crisis beds and an additional 4 adult transition beds, all for people on the DD waiver. These homes are typically located in regular neighborhoods and serve 4 people at a time. The environments have been modified to increase safety and security during behavior stabilization. The staff at these locations are trained in managing and supporting individuals with high behavioral needs. Each county has their own internal process for making a referral to place someone in the crisis bed pool. Be sure to check with your supervisor for more information. MCCP facilitates placement for crisis homes located throughout the metro area. All of the homes are for individuals on the DD waiver, with the exception of the home in Andover, which serves kids and adolescents on the CADI waiver. The typical stay is 45 days for all of the homes except for the adult transition home, which is 90 days. Note that there is not currently a home for adults on the CADI waiver. Once a referral is made, a MCCP specialist will contact the case manager and guardian to triage the situation, explain the process, and gather information. They will also request a signed release of information from the guardian to share pertinent information with potential crisis home providers. While the person is in the crisis bed pool, we request that updates be made on a regular basis to the MCCP specialist, especially changes in placement, behavior changes, hospitalization, or medication changes. If the referral is for a crisis bed only, the main contact will be the INR specialist. If there is an open TA case, the case manager should connect with the positive support specialist. Information from updates is used when making prioritizations, making it challenging to prioritize a person without current information. Once the person has been prioritized for a potentially open bed, MCCP will send a housing referral to the crisis home. The crisis home will then review the information and contact MCCP with their decision to either accept or decline the referral. If the referral is declined, the person will remain in the pool. If the referral is accepted, an intake physical, current medication orders, and other paperwork will be requested. An intake meeting and admission date will then be scheduled with the provider. After a person moves into a crisis bed placement, the team will meet every 2 weeks for updates on stabilization and behavior plans, along with a discussion of a transition support plan to successfully move out of the crisis home. It is required that the case manager and guardian attend these meetings. The crisis home admits are scheduled up to 45 days, with the exception of the transition home, which is 90 days. The focus of transition planning begins at admission. The counties have established certain expectations associated with each crisis bed placement. The expectations include the need to preserve and maintain people in their natural setting, reduce the use of inappropriate and/or prolonged placement of a client within a crisis home, and starting with the day of admission to begin developing the best transition support plan possible for the person. MCCP will attend crisis home meetings as available and provide ongoing updates to the 7 counties regarding best practice implementation. If a new placement is required, the steering committee requests a list of the potential providers that have been contacted to be shared with the team at each 2-week meeting. Here are some reminders and clarification on things we do not do. We do not offer immediate placement. Instead, when an individual is discharged, prioritization for the open bed occurs. It is not on a specific timeline or schedule. We also do not require anyone to use a crisis bed. Placement is voluntary, and the decision to move a person out of the home can be made at any time. The crisis beds are short-term and not meant to be a long-term placement. We are also not able to make specific recommendations for alternative placements or make recommendations for specific medical or therapeutic providers. For these placements, we are not able to grant specific requests to locations, as availability is based on where there is an open bed. It is also important to note that while a person is in a crisis bed home, MCCP is not able to continue with ongoing TA support. TA can restart, if appropriate, when it comes time for the person to transition back home or to a new setting. In addition to the services that we have previously discussed, MCCP offers supplemental services with an open TA case. MCCP provides a 24-hour emergency support line that will be given to the team by the PSS if appropriate. This line is answered by a positive support specialist and is open to both providers and caregivers. We have a psychiatric nurse on site for consultation, and we can provide a one-time consult with a psychologist or psychiatrist based on need. We also do non-client specific trainings for organizations such as ARM, MSSA, and other providers throughout the metro area. Finally, we serve as the contact point for community support services with the state.
Here is an overview of the eligibility criteria and costs associated with technical assistance. In order to be eligible, people must have a qualifying intellectual disability/related condition or have a mental health diagnosis and be on the CADI waiver. They need to live and have funding within the 7-county metro area, or if they're outside of the area, prior approval is needed. They also need to have approval from the person's DD or CADI case manager. Regarding funding, costs are determined by services provided and they're funded through their waiver. For individuals on the DD waiver, an agreement is in place for us to work with them regardless of funding as long as they have a county case manager in the metro area. If technical assistance is provided for an individual on a CADI waiver, it is considered fee for service. It is required that a person has an active CADI waiver for service or a county commitment to secure funding in a timely fashion that is retroactive to the date of referral. The total cost for technical assistance is $30.30 per unit if you're living in county, or $33.95 per unit if you're out of county. There's a total of 120 15-minute units. The counties have agreed to build in a cushion in order to reduce the need for extension requests if additional support is deemed necessary. The cushion increases the parameters to 120 days and 150 units. Units get billed for everything done for the case, including visits, attendance at meetings, creation of written suggestions or crisis plans and accompanying tools, reviewing data and documents provided by the team, and also drive time. Services provided may vary per case and are dependent upon the individual's need. Be sure to explain the CDCS billing to a guardian and get their approval before making the referral. If you have questions or want to know the specifics for staff augmentation or amounts for crisis beds, please call us with those questions. When deciding to make a referral or not, review the eligibility criteria for the specific person you are considering. Are they on a covered waiver? Do they live in the metro area? Does the county approve? Does the guardian approve of services? If they are their own guardian, are they on board with the services? If they are eligible, then look at the risk. Is the person at risk of hospitalization, or do they have frequent police and 911 involvement? Is there risk of physical harm to themselves or others? Does the person's behavior interfere with their ability to remain in their residence, their job, their day program, or their school? Have their behavioral health symptoms continued to escalate? If the answer is yes, a referral to MCCP might be helpful. Remember, don't wait for things to fall apart. Early involvement can lower the risk of a major crisis. To recap, MCCP offers three main services: technical assistance, information and referral, which is crisis bed placement, and staff augmentation, with an open TA case. When you make the referral, you can select technical assistance, information and referral, or both. If you want staff augmentation, be sure to select technical assistance also. Now that you're ready to make a referral, you can do it one of three ways. You can do it via email, fax, or over the phone. If you're going to be using email or fax, you can download it from our website. Go to www.metrocrisis.org and then click the Make a Referral button in the upper right corner, or you can scroll down to the Make a Referral button in the middle of the screen. Please be sure to fill out all of the information completely, as missing or inaccurate information causes delays in getting started. If you're emailing or faxing the referral, also send in pertinent documents such as the CSP, CSSP, IAPP, HSP, IEP, etc. If you are calling it in, the specialist assisting you will give you the referral's email to send it to. Everything can be emailed to mccp-referrals@mountolivet-mora.org, or it can be faxed to 612-869-6743. If the referral is more urgent or you need assistance with the process, don't hesitate to call us at 612-869-6811. Someone is available to help guide you through the process Monday through Friday, 8 a.m. to 4 p.m. Note, referrals are processed within 24 business hours of submission, as long as the referral has all the information. And the 90 days starts when the referral is processed. Case managers will also receive an email confirmation that their referral has been processed. If you don't receive this email, please give us a call to follow up and check on the status of your referral. This helps to ensure that we received it and there wasn't a glitch in technology.
To help get services off to a good start, MCCP needs the help of case managers. In order to proceed with supports after a referral has been made, we need to have the guardian's approval. It helps if the case manager and guardian have already talked about supports and they are on board and expecting our call. This is especially important if the person is his or her own guardian. In cases where there is CDCS funding, guardians must approve the cost of their budget. Services cannot take place without their approval. It can be an awkward and confusing conversation with the guardian if they are unaware of the referral when we call. In addition to informing guardians about MCCP services, case managers are key in coordinating services and transitions. It is helpful if the case manager has ongoing involvement with the specialist throughout the case, including changes to the case manager or other team members and invitations to MCCP for any upcoming team meetings. During the progression of the case, it would also be the case manager's role to assist with any referrals that are discussed. MCCP is not able to make referrals to outside resources on behalf of the teams we work with. Once MCCP is transitioning out from a team, it is important that the case manager continue with following up with the team and helping to refer the team back to plans and tools that were created. If there is a change in supervisors at a house or day program, reach out to the new contact to ensure they have the documents from MCCP's involvement. If a new case manager will be taking over, ensure that all tools and resources get passed on to that person. If significant changes to a person's behavioral health symptoms occur, consider making a re-referral if necessary. Thank you for taking the time to learn about MCCP services and how to access them. If you have any questions, please don't hesitate to reach out to us at 612-869-6811.